welcome to Itenef Healthcare Solutions webinar. We're excited to share a webinar, Monitoring Payer Performance. Are you leaving money on the table? My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for Itenef. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. We'll be sending out a copy of the slides and the recording within the next week. Next, for those of you who aren't familiar with Itenef, I want to share a bit of who we are with you. We specialize specifically in NextGen healthcare, and we're passionate about providing solutions to our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything NextGen, and we also have two add-on productivity solutions for NextGen, ChartGuard and Refund Manager. Next, I wanted to mention some upcoming webinars that we have. Refund Manager for NextGen is going to be on March 28th. In it, we're going to present a demo of our NextGen add-on product that helps you streamline your refund and credit processing procedure. Then on March 24th, we're going to, May 24th, we're going to do an educational webinar on using familiar tools for patient engagement and outreach. In it, we're going to explore traditional patient engagement tools such as appointment reminders, statements, collections, and we're also going to look at the impact automation can have on population health and other quality care programs and initiatives. Okay, so back to today's webinar. At the end of the presentation, we're going to open the floor up to questions from you. We'll answer all the questions in the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Dottie Pinnick is Managing Consultant at Itenef. Dottie is a true NextGen PM expert, and we're eager to learn from all of her expertise. And Cindy Kincaid, VP of Client Solutions at Itenef, is also going to be here to help with questions at the end. So Dottie, I'm going to go ahead and pass the webinar off to you. Please feel free to get started when you're ready.
Hi, everyone. Today our topic is monitoring payer performance. Are you leaving money on the table? It's a pretty extensive topic, but what we're going to try to focus on today are these things. First of all, looking at what to analyze. Second, selecting data so that we make sure that the comparisons, that the data we analyze is analyzed by comparison correctly. Some other factors to consider during the analysis, and last but not least, using the NextGen system, what reports are best to use for this type of analysis. So the first thing we're going to talk about is what to analyze. It can be kind of overwhelming to look at the big picture of everything AR. So sometimes it's better to look at the different factors that may be involved in the analysis so that you can determine exactly what analysis would be most valuable to your practice. I worked for NextGen for a long time, and I worked with many, many clients. And I can tell you that no client ever said to me, oh, don't worry about us, we're just like everybody else. So understanding what to analyze for your practice is partially understanding what makes you unique and what your specific needs are. One way to look at the analysis would be to begin by examining a specific payer or specific types of payer. Let's say you know that you think you have a problem with Aetna HMO, so you pretty much already know what payer you want to look at. Or maybe it's your HMOs in general. You want to look at your HMOs. But there are other ways to consider when you're deciding what to analyze. One of the things to consider is, are you looking at your highest volume codes? If you follow the 80-20 rule, and in many practices, 20% of the codes account for 80% of the revenue. So it's really important that we have the ability not only to look, because sometimes it can be overwhelming, particularly if you have a multiple scope, multiple providers in a large scope of services that encompass hundreds of codes. So determining those high volume codes can really help you focus your analysis in the right place. Another option, again, depending on your unique practice needs, might be to focus on specific codes or services. Let's say you're considering or you've recently added a new service and you want to see how you're being reimbursed for that specific service or group of services. Let's say, for example, that your radiology department has been under some scrutiny because the cost of providing those services is rising. What they want to analyze is actually the Department of Radiology or those specific radiology codes. Another way to consider reimbursement might just be by looking at the overall performance of your payers relative to each other. Let's focus on our poorest performing payers. Instead of trying to determine sort of what you think is wrong, let's look at all the payers and try to focus and evaluate them relative to each other. So see, these are some of the things that we're going to review today, and I'm going to give you some details on how to accomplish these things when we determine what to analyze. So starting sort of one place might be to look at the overall collection percentage of your practice. In this report, I've used the service item summary in its most basic form just to pull my financial classes to look at how many services have been performed, the charges. I also added a column here called charge less adjustment amount. When practices evaluate their net collections, some practices evaluate the payment amount against the charge amount. But I've had other practice managers who've said, no, I want to take the adjustments out because I can't control those. So I want to take charges less adjustments and make my net collections percentage relative to that calculation. The nice thing about, well, there are two things about NextGen. It does not do the calculation for you, but it does allow you to put this into Excel and perform that net collections calculation based on your own practice needs. So you can drop this into Excel and get a practice collection percentage by financial class. And that might be, depending upon how your financial classes are set up, that might be one thing that points you in the direction of what you need to analyze. It's really important when you're performing these analyses to be able to do apples to apples comparisons. And what we're going to talk about next is some methods that you can employ to select data to make sure that your comparative analysis is truly apples to apples. There are a lot of different factors that can impact your compensation, and so we're going to review some of them to make sure that you're taking all those things into account when you do these analyses. One of the nice features in the NextGen system is the ability to subgroup things that help you organize data for reporting. So NextGen has subgroups at many levels. They have payer subgroups, provider subgroups, location subgroups, it goes on and on. But the three we're going to focus on today are the payers, providers, and locations. What this allows you to do is create your own list of ways you want to subgroup things, and I'll show you some examples as we go. But to do this in the master list, each practice is able to create their own subgroup labels and then attach them to the appropriate label, to the appropriate records. So, for example, let's talk about payer subgroupings. All of you are familiar with financial classes. The challenge with financial classes is that you can have competing priorities for how those financial classes are broken up. So I would say in the majority of practices that I've worked with, they have your basic Medicare, commercial, Medicaid. And that very well may suit a lot of the top-level reporting needs. It may also be the way you break up your AR, either to task it or to have your staff work it from a report. But it may or may not be the best way to do comparative analysis when you really want to drill down to the detail. So one of the options that NextGen provides is the ability to use payer subgroups that can be totally different than your financial classes. So for example, you may have government payers, Medicare and Medicaid. They wouldn't necessarily be in the same financial class, but because you can't really control that reimbursement, you may want to compare your contracted reimbursement to your government payer reimbursement, because those contracts, you have some negotiating capabilities, whereas with Medicare and Medicaid, those are government fee schedules. Another example would be using this for Medicare versus managed Medicare. Many of you have participate in managed Medicare and or managed Medicaid plans. So depending on the practice, some of you have those managed Medicare and managed Medicaid plans. You may not have a separate financial class for them. They may either fall into the Medicare financial class or to the commercial financial class, depending on how you've set your system up at the beginning. But one of the things some practices will do is they will create a subgroup and pull all those managed Medicare and or managed Medicaid plans into the subgroup. That allows them to isolate just those managed plans and be able to compare the reimbursement not only to each other, but to the actual Medicare contract. Another thing that subgrouping can be used for is to pull out your HMO versus your PPO plans. For example, Aetna, all your Aetna payers may be in the commercial financial class, but you may want to pull out Aetna versus Cigna versus Humana HMO plans and compare those separately. This is not an exhaustive list. It's just some examples to kind of get your mind to start thinking about how your payers can be subcategorized for the purposes of evaluation and comparison. So in this example, I've used my subgroup to pull apart my government payers, my HMOs, and my PPOs. And now when I drop this into Excel to do my net collections, I can see my net collections of my PPO plans versus my HMO versus my government payer. And again, it depends upon how you've chosen to subgroup these based on your unique payer mix and your unique practice. Another way to use subgroups is at the provider level. Most of you know that there can be compensation variances based on either primary care. Some specialists have carve-outs or separate contracts. And there are often times where mid-level versus actual physicians are reimbursed differently depending upon the incident to rules that you're billing under. So what I've given you here is an example of how you can break apart your provider into subgroups so that when you're reporting and evaluating compensation, you can evaluate your, for example, primary care versus surgical, or surgical versus non-surgical. If you're in an ophthalmology practice, I often see this where they put the ophthalmologist in one category and the optometrist in another. And then the second subgroup can be used to differentiate your physicians from your mid-level providers, as an example. The last subgroup I want to talk about is location. So depending on the size of your practice, we have some clients that have practices that span multiple states or certainly span multiple reimbursement geographic the gypsy geographical areas. So one example of how these locations can be subgrouped would be by the regional areas, so that you know your Medicare variances are going to be expected by region, and maybe even your commercial contracts would be different by region. And secondly, taking into account your site of service differential, you may want to break apart your clinic locations from your facility locations. This becomes a lot more important when you're looking at average reimbursement by encounter. For example, you would expect those hospital encounters done in a facility location to have a higher net charge and or net receipt. But even for purposes of comparing contracts, you may be hit with a site of service differential reduction that you would not want to put into your calculation. So one way is to use the location subgroup to avoid that. Lastly, this isn't really a subgroup, but the logic of subgroup is the same using departments and modalities. So for example, you may want to break apart your evaluation and management codes, your radiology codes, your lab codes. Maybe you want to use lab as a department, and maybe you want to use CLIA waived versus non-CLIA waived as your modality. Either way, using the departments and modalities not only segregates this and allows you to report it, but it also allows you to isolate and focus on things. So if I just want to look at my E&M codes by provider, having them in a department from a reporting perspective makes it very easy to look at. In addition to that, there are some other factors that we have to consider when we're running these reports, and I'm just going to touch on those briefly. These are a couple of the main ones that I find when I'm helping clients. One is, if you are doing net collections, you want to make sure that your reports have allowed enough lag time in the reporting period so that you're capturing all the payments. Because if you run a net collections on January charges in January, you'll get what's current, but that may not be enough time to adequately evaluate the true performance. So we want to consider the lag time, especially when we're looking at net collections, to give the payers enough time to pay. The second thing that we want to talk about is modifiers. One of the big challenges is that many of our codes are modified depending upon the services you provide. It could be an AS modifier, a 2.6 modifier, a TC, a 50 modifier, which could reasonably be expected to increase the reimbursement. So when we're doing this analysis and we're looking at these reports, I want to kind of put into your head, some of you have created different SIMs to indicate the modified codes, like you might have a 7102.026 modifier as a SIM. And if you do, then running the report by SIM code will often capture those, at least a large portion of those modified codes. But if it doesn't, then one of the tools available to you is filter 2 of the reports. So filter 2 can be used to either isolate modified codes or simply eliminate them from the overall evaluation. In my example, I've chosen to pick filter 2 where the modifier equals blank, and what that's going to do is completely eliminate any modified codes from the analysis. Now I could pick filter 2 modifier 1 equals 2.6 and look at all my technical my professional components. So again, it's a little bit tricky when you're doing this at a CPT code level, but you do want to take into account those modifiers. So I've given you a lot to think about already. The next part, I want to spend a few minutes and walk you through what reports in the NextGen system are best to use for the analysis. I don't have to tell you that NextGen has a million reporting options, and sometimes that's a bad thing, but it can be a good thing if you know exactly what you want to do. So these are not the only two reports that can be used for your analysis, but I have found that they are the ones I most commonly use for my analysis, which are the service item summary and the contractual analysis report. And the reason I use these two is because of the way the logic works. And as we review each one of them, I'll talk to you a little bit about the logic and why I think it's helpful to be used in the analysis. So first and foremost, the service item summary. The service item summary is a very unique report because it has a couple of properties that if you understand those properties, it can really help you get a lot of data out of your system. The first property is that this report ties all transactions to their associated charges. So for example, if the charge happened in January and the January charge appears on the report, unless it's restricted by the transaction date, all transactions for that January charge will appear as well. That enables it to become a net collections report. So for example, if I have an office visit in January and I pay a copay, then that copay plus the insurance payment that may happen in February will all tie back to that 99213 charge. So that logic helps me to use this report as my net collection. Another thing that's somewhat unique about this report, particularly as it compares to the contractual and analysis report, the service item summary collapses data to the lowest common denominator. So what I mean by that is that the columns that you select in the service item summary, the more columns you select, the bigger your report will be. So if the only column that I select on my report is the service item and the charge, it will collapse that data down to just the service item level. If I pick the service item, the patient name, and the charge, it will give me one line for every single patient because that's the lowest common denominator. And I want to show you a couple of examples. So in this example, the only columns that I've selected are the service item, the count, and that is from the charge entry count, the charge amount, and the payment amount. So by selecting only those four columns, it gives me one line in the report for each service item. Now, I could also do this by CPT code, and some of you would have reason to run this by CPT code than by SIM. So I have to let you use your own discretion as to which one would work better for you. Some of you have multiple SIMs that represent the exact same CPT code for your own unique points, and you may want it at the SIM level, but if you want it at the CPT code level, you would replace service item with CPT code in your report filter. So by putting it in descending order on the sorting tab, I've now said, okay, give me my highest volume codes by the number of times that they were used. So this, as you can see from the example, my most common code is a 99213, and it was used during this reporting period 329 times. Another way to determine your highest volume code would to be run this exact same report, but instead of doing it by the number of services that were performed, do it by the amount that you were paid. So in my example, my top two codes are the same regardless of if I look at the number of times it was performed or the number of times it was paid. But that may not be true if you have a high volume radiology department that does MRIs or a nuclear cardiology department that performs those high dollar services. You may do far less in number, but far more in dollar value. So those are some of the things that as a unique practice you have to take into consideration. But I do like to run the report both ways. Or you can do it by charge amount. I like to do it by payment amount, so I know that when I talk about high volume, I'm talking about high volumes of dollars coming into practice. Once you've identified your high volume codes, so as you're evaluating your payer performance, I know a lot of you are responsible for contracting, for doing the contracting in your practice. Well, those reports I've just shown you can help you identify which codes to focus on when you're negotiating the contract. One little tip that I do sometimes when I'm helping clients work through this is we will run those reports, identify their top codes, either top 20 or top 20% if they have a wide scope of services, and we actually go in and use the modality to designate them as high volume codes. Then when I'm running a report, I can filter, use filter 2 to pick out just that modality and really focus on my reimbursement for my high dollar codes or high volume codes. Another reason that I like the service item summary is because of the many date range options available to me. I'm going to try to explain this as best I can, so hopefully I get it right the first time. I told you that this report ties all associated transactions back to the charges. So in this example that I've given you, if my charge date is in the month of January, I'm asking the system to return for me all associated payments for those charges that I collected from the first day of January to the 15th of March. So that's going to allow me to use the service item summary as my way to evaluate the timeliness of the payments. So these date limitations are going to show me that for these financial classes or payers or however else you've chosen to break this up, how much of that money did I get back within the first 45 days? So for January charges, by the middle of March, this is how much I had already collected on those January charges. Because in the end, 6 months from now, the payers may be more equitable, but in the first 45 days, which payers are paying me as a percentage less? That's one way to look at the data and evaluate the actual performance of a payer. Another thing that I use the service item summary for and I find it very useful, is remember I told you it collapses data to the lowest common denominator, or it can expand the data all the way out to give you one line for every service. But depending on how you've got the report set up, the system has the ability to calculate averages. And so instead of having to do math on everything, the system will allow me to calculate averages for all of the subtotals and totals within the report. The only other thing that I would say as somewhat of a caveat, or just as a don't forget, that unless you specifically exclude the charges that have had no payment at all, they're going to be included in your calculation when we look at average payments. So if I've got 5 services and one of them has not been paid, that 0 payment is going to be included in my average. Now, some of you might say, well, good, I want that 0 payment included because I didn't get any money, and that is part of the calculation. But there are going to be others who really want to look at just the adjudicated portion. So again, this is where everybody's going to be a little bit different in how they want to consider the data. But unless you specifically include 0 payments, they're going to be part of your average calculation. So how would I actually do that if I wanted to use the report for averages? Well, when I'm working with the report, the first thing I'm going to do is if I've created average calculations, I want to make sure that I rename the columns to reflect what the reader is actually seeing. So by right-clicking on the column amount, you can rename that column from payment amount to average payment amount. Likewise, charge and adjustment amount, I would simply right-click the column and type in a new name. Now, just if you've never used this feature before, this change in the column name only impacts the current memorized report. If I come back and I run this report from scratch tomorrow, starting at reports, monthly, service item summary, it's not going to have these new column names. The new names are only going to be reflected in the memorized report that I'm creating. So I would rename all the columns that I'm going to be averaging. The second thing I would do is go into the Totals tab. The Totals tab typically will default to have a green check in the sum, but for purposes of averaging, I'm going to remove the green check from the sum and place it on the average column. This is going to provide me the ability for the system to calculate my averages for the payment amount, adjustment amount, etc. So that's how I change from adding up the values to averaging the values. So I've given you an example here of a report configuration that will allow you to determine the average reimbursement by either service item or SIM. In this example, I picked service item. So I want to go over it so that there's no confusion, because it can be a little confusing. In determining my highest volume codes, I only picked the CPT code, the charge, and the amount. I had no other identifying data that would separate those lines so that because I wanted it to roll up to one line. In order to calculate an average, I need to do something totally different. I need to add unique identifying data so that I get one line per charge. And the best way to do that is to make each encounter unique and then each SIM unique. And I also added date of service because sometimes for hospital charges, if you do a lot of hospital visits, they will have the same CPT code, but they will have a different date of service. So that should, for the majority of my codes, now nothing is foolproof, but the majority of my codes, this should break the service item summary out so that it returns one line item per encounter, per date of service, per CPT code. And that will, if grouped by CPT code, as I've done in my example, that's going to give me the ability to compare CPT code by CPT code what my average reimbursement amount is. So as you can see, my average for a 99213, I did 331 of them. My average charge was $111. My average reimbursement was $55.95. That's sort of a high-level top-down, but using all the other things that we learned, for example, how to subgroup data, now I can take this average calculation and start really looking at it in a different way. If I only want to focus on my E&M codes, then I can group it first by department. What I find sometimes is this, particularly again, when you have a big scope of service within your practice, all this data is great, but it's overwhelming, and sometimes you just don't know where to start. That's why being able to look at your high volume codes, or maybe your codes just for one department at a time, makes a little bit more sense, and it certainly makes it a less daunting task. Another way to do it is by provider. We talked about this. I may want to look at my codes, my E&M codes, by type of provider. So is there really a significant difference between my primary care, my specialist, or my surgical providers? In your world, there may be no difference. You may want to look at it by mid-level versus physician, because when you're looking at this, you might expect to see a difference, or you might expect not to see a difference. Again, it's all sort of depending upon your provider composition. One of the most interesting ways that I find to look at the data is by either payer subgroup or financial class. Because I know that the majority of people use financial class, I went ahead and used that as my example. So what I've done in this report is first group it. It's that same report that I showed you all the columns for, but I first grouped it by CPT code, and secondly by financial class. So now, although I realize that if I look right here, the compensation for my 99213 is $55.95. That's my average compensation. I can compare that relatively one financial class to another and see, again, if I'm focusing on my high volume codes, it really gives me a way to look and see who my best performers are overall. So the service item summary is a good way to look sort of top down, and in summary, the service item summary is a good way to sort of look top down at your compensation. It's a good way to compare things. It's a really good way to give you sort of a magnifying glass to look for the needle in the haystack, or to understand what you should be focusing on. Whereas The contractual analysis report is a way to get you much more drilled down into some very specific data. So it is similar in logic to the service item summary in a lot of ways, but one of the ways that it's very different is it gives you one line in the report for every charge. So it's really going to give you the best way to look at the details. It's useful to use this report. It's most useful if you have a contract set up, because if you have a contract set up, then it's a good way to see what the contract says you're supposed to get paid and compare that against what you're actually being paid. So that certainly is one of the benefits of the contractual analysis report. However, not all clients go to the trouble and effort to set up a report for every single payer. And just because you don't have reports set up for every payer doesn't mean that this report can't still be very beneficial. So let's talk about the logic just for a minute. Very similar to the service item summary, it has two key similarities. One, it ties the charges and their associated transactions. So in these first 3 dates of charge ranges, so either by create date, by process date, by service date, if the charge appears on the report, then the associated transactions will appear. So similar to the service item summary, it will show you net collections. Another thing that's really nice about this report is it has those same multiple date options that the service item summary does. So I can look at charges for last year that were paid either within 45 days, or I can look at charges for last year that didn't get paid until this year. So those 2 date range options, the ones for charges and the ones for transactions, work together to associate the transactions within the date range to the charges that appear on the report. Another thing that they added in recent versions, I'm not sure, I think it was added about 5.7, is the ability to do modeling against other contracts. So I can say, give me what is in my Blue Cross, give me my Blue Cross payers, and tell me what I would have been paid for those Blue Cross charges if I had been paid using the Medicare contract. So this drop-down list here will have the contracts that are in your system. So even if the only contract you have loaded is Medicare, you can compare other payers to the Medicare contract. You can compare Cigna to the Aetna contract and see what you actually got paid by Cigna if you had been contracted at the same rates you were with Aetna. This can be very useful from a decision support standpoint if you're looking at recontracting efforts. There are a lot of ways this can be used, and so we have some time limitations about talking about all of them, but it is important to realize that you don't have to have a contract. In UD3, there is this brand new option called Include Payers Without Attached Contracts. So before NextGen added this option in UD3, if you're on a version prior to that, and I was working with clients who had that problem, we would create a zero dummy contract just to be able to use this report. You don't have to do that anymore. In UD3, the system will allow you to pick any payer and run it against this contract. Now, that's helpful in modeling, but this report is really nice because it has some really interesting features and columns that not all of the other reports have, and it's one of the reasons it's my favorite to use. So let's take a look at some common things about this report that sort of make it distinct and separate from other reports. One is the contractual versus the actual and the difference. So for those of you who have a contract set up, the system will say, according to the contract, you were supposed to get, the allowed amount was supposed to be $150, and the payment amount was supposed to be this, and it will also say when that transaction was posted, the actual allowed amount entered into the system was this, and the payment was this, and the adjustment was this, and it will let you compare and contrast those because it calculates the difference. Normally, when I'm doing this, I don't do it by paid amount. I look at allowed amount because your deductibles and co-insurances can skew what you're supposed to get paid, whereas nothing really should skew what you're supposed to be allowed. Another nice thing about this is the payment posting indicator. So that PMT PST column is going to tell me whether or not an insurance transaction or third-party transaction has been posted. So if I only want to look at claims that have been adjudicated, I can use a filter, which I'll show you in a minute, to exclude that. But this will tell me which claims have been paid and which ones have not. Another thing that makes this a little bit different from a evaluation perspective is that it gives me two choices for reason codes. It gives me my reason code and my zero payment reason code. So my reason code will be any transaction that's posted with reason code. My zero payment should be transactions that are posted, reasons that are posted against a $0. The other thing that's really kind of nice about this report is it gives you current outstanding balances, and it shows you payments by patient and third party. So using the contractual analysis, one common way of grouping this is by service item. So what I'll do when I'm running this is I'll just run this report in detail by service item, and it'll let me look at all of my service items compared to each other. So I can even group it by service item, and then I can see how each one of my codes is paid line by line. If I'm trying to evaluate, again, as we discussed, a specific department like evaluation and management or radiology, I could group it by that, or I could isolate it using the filter by that. Another thing to consider, again, are my location subgroups and my provider subgroups, so that when I'm evaluating these payments line by line, I'm actually looking at, it'll help me spot any variances between providers or locations pretty quickly. In terms of sorting it, when I sort the data, one of the best ways I find to do it is by the actual allowed amount and then by the reason code, so that I can tell if I'm being if my actual allowed amount is 0 and I have a whole bunch of CO28s. Those will all group together, and I can tell what my common denials are. By difference in allowed amount, that'll also tell me, if I put them in order by difference in allowed amount, it'll tell me the ones that are overpaid versus underpaid pretty quickly. Again, depending on the date range that I'm evaluating, sometimes I'll put them by date of service. If I see that sometimes I'll see that they were paying along just fine. I was getting $33.27, and then randomly I see these $34 or $32. Sometimes putting them by date of service order can help you find when they stopped paying one way and started paying the other way. and then looking at them by outstanding balances so that I make sure I focus on the bigger balances. So here's an example of that report. I almost always add the modifier filter, and sometimes I'll even group them by modifier, or just go to filter 2 like I showed you before and completely eliminate modified codes. Filter 2 options, again, I told you I would explain this to you. You could pick only those that have been posted so that you don't look at unadjudicated claims. And then to narrow down the report, one of the nice things about this report is it can be run and given to your staff to call the insurance company or send it to your provider representative, because you can run it using filter 2 to isolate where the difference in the actual and the contracted allowed amount are not the same. So this will just tell you the ones that are not paid correctly, and anything that's paid according to contract won't show on the report. In summary, I read this, I found this interesting, so I thought I'd share it with you. According to the AMA payer report card, nearly 1 in 5 claims is paid incorrectly. And what this tells me is that evaluating your payers and their performance is really critical for the financial health of your practice.
All right. Thank you, Dottie. I just wanted to take everyone through this. And first of all, welcome Dottie aboard to the iTenant family. She has joined us after having a lot of years at NextGen and brings to us a wealth of PM knowledge. And we're going to be adding more webinars and more opportunities to work with Dottie if you're interested in anything that Dottie has to offer or can assist with any of your PM questions. So uncertain where your practice stands, let iTenant help. We can help you by assessing your current readiness. We can provide recommendations, and we can implement new procedures and processes. You might also want to consider our macro packages, with macro coming up and moving into full force. We have the macro fundamentals, the intermediate package, and the expert package. If you'd like more information on those, you can certainly reach out to me or anyone at iTenant. And finally, if you're looking for next steps, you can visit us at itenant.com. You can sign up for our webinars and blog. You can consider our 3-day fixed-price on-site consultations, which consist of clinical workflow reviews, revenue cycle and front office, technology and performance reviews. And then you can test drive our products, Refund Manager, ChartGuard, and some of the other items. So we're about out of time, so let's turn it over to questions. I'll see if there's anyone that has any questions on the data that Dottie covered, or any questions for me.
Okay, so again, questions can be entered in the questions webinar or in the questions panel of the webinar control panel, and we're just going to take them in the order that we received them. We only have 2 so far, so if you have a question, now is a great time to ask them. We're going to be able to get to them all. So first question, if I rename a column, can other users see the new column names I selected?
So if you rename a column and another user runs that memorized report, then those column names are available to anyone who uses that memorized report.
Great, thank you for that clarification, Dottie. Last question, can you use the feature to calculate averages on all reports?
Yes, all of the reports have a totals tab, and the feature that I showed you on how to rename them is available on all reports, and the averages feature is available on all reports.
Okay, great, thank you. You see both Dottie and Cindy's information up on the screen, so if you have any questions that you think of after the webinar, please don't hesitate to reach out to them. You can always ask us anything on social media. Follow us on social media. We do weekly tech tips. We announce our webinars there. We post links to recordings of our webinars. Speaking of which, I will be sending out a link to the recording of this webinar along with the slides within the next week. So keep your eyes out for that, and keep your eyes out for future webinar invites. There's going to be a bunch of great ones coming up, so we hope to see you at those. And thank you, Cindy. Thank you, Dottie. Dottie, I know you put a lot of time and effort into making this presentation, so thank you so much. It definitely showed. And I hope that everybody has a great day.
All right, thank you. Goodbye, everybody.
Thanks, guys.